Well, hi everyone, it's Pete here for the Pain Toolkit, and welcome to the fifth Pain Toolkit in conversation. And boy, oh boy, we've got a good setup this month. We've got some new faces that'll be joining us. Some people couldn't make it, but we've got other dudes who come on board. And so I'll tell you what, before we go any further, can I just ask, we just go around the group so they can introduce each other. And because I'm a gentleman, I always pick on a young lady first. So Mary, you want to start us off? Just briefly introduce yourself, where you're from and what do you do?
I'm Mary, obviously. I'm from Australia, and I've been working in the field of pain advocacy for probably about 14 or 15 years now. I've been involved in many different things, a lot of local committees and an international committee, and I just love what I do. I really enjoy it. So, and I also have chronic neuropathic pain. I should mention that, I guess.
Thanks, Mary. Virginia.
Hi, Pete. Nice to be back again. I'm Virginia McIntyre. I'm from Canada, from Nova Scotia, and I'm the president of the People in Pain Network, which is an organization that supports people living with pain through peer support, which really embraces this self-management thing. And I do a lot of advocating for pain and pain resources in Canada.
Thanks very much, Susan.
Hi, everyone. Nice to see everyone again. My name's Susan Reid-Schellinck. I'm an occupational therapist, and I am on the other end of Canada than Virginia, the very other West Coast end. Both are great. Yeah, and I'm really happy to be here.
And Helen.
Thanks, Pete. Hi, everyone. I'm Helen Roome. I'm an occupational therapist in independent practice on the east coast of South Africa.
Thanks very much. Jerry.
Jerry Durham, physiotherapist by training, currently have a business, so I don't work with pain people, yet I have a business of trying to bring the whole team together, front desk team, back office team, providers together to serve our people. We're serving our patients better. So physiotherapy background of about 30 years, then this whole team training thing for about 8 years, currently in California, where it's almost happy hour.
Thanks. Thanks, Jerry. And Seb?
Yeah, hi, my name's Sebastian. I'm also I'm in Canada, in Calgary, so somewhere in between Virginia and Sioux, a little closer to Sioux. I'm actually a chiropractor. I graduated in June of 2023, so I'm very young into my career and really happy and honored to be here with you guys today. I spent half my time in private practice where I focused on rehab and self-management, and that's how I met Pete, obviously. And then the other half of my time I spend more in public healthcare, working alongside a group of pain docs. And yeah, that's me.
Thanks, Seb. Dermot? Dermot? Yeah, you have to go on, your microphone's off at the moment.
Good morning, gang. Diarmuid McCoy is my name. I'm originally from Ireland, but I live and work here in Australia. I'm a pain specialist. I've been at this for a little over 30 years. And I met Pete, but I think you and I had a conversation last year about what we do. I'm involved in the Faculty of Pain Medicine, and we have a teaching program for the medical students as well. So I'd like to think we're doing our little bit here.
Okay, thanks, Dermot. Last but not least, Dave.
Yeah, thanks. Nice to meet you all. I'm Dave. I'm a pain self-manager. Been talking to Pete for the last 5 years or so, and he's dragging me more and more into helping him with the pain toolkit. So he thought, hey, you don't need to sleep on a Friday night, so you can join this call. So here I am at 10 o'clock on a Friday night, which is only 2 hours past my usual bedtime.
There you go. Oh no, we've got a late comer. We got hemp all the way over there in New Zealand. Perhaps they've got a different time over here in New Zealand. Anyway, so tonight's theme, I think it was agreed on the last conversation. This to me, I think, is probably the most important one. I think all our conversations have been been important and useful. But for me, it's I guess over the years I've been looking at how do we get self-management into mainstream, because at the moment, well, for as long as I've been involved in it now, self-management is sort of a bit of an add-on. I always remember a doctor in Canada telling me quite a few years ago that self-management was never taught while they was in medical school, etc. And it was expected self-management, pain self-management was expected they had to learn it while on the job. And there wasn't any training facilities or anything like that, so they had to pick it up. But now I think supported self-management has become it's not so much the how can I put it? What's the old saying? It's like always been a bridesmaid and never the bride sort of thing, like, or be the groom but never the groom, or you know what I mean. Anyway, it's always been second fiddler. But now I don't know, in especially in the last 10 or so years, or especially definitely in the last 5 years, it is becoming quite prominent. And even our NHS here in the UK, there on their website, there's a massive section about self-management and etc. and or supported self-management. And but the thing is and I've been this week I've been posting quite a bit about I'm just trying to make people think really about how do we make supported self-management get into mainstream healthcare, and say not as an add-on, you know, as like a poor relation, etc. And how to do that. And I've been putting out there asking, how do we do this? How do we do that? And some people have been coming back and telling me that this is what they're doing in their area. But you know, one of the things when I worked in the NHS and when I worked on a program called the Expert Patients Program, one of our remits wasn't about just working in certain areas. It was about building capacity, getting the word out there, and that was our remit as well. It wasn't sort of going to, you know, supporting and teaching what we call the usual suspects, etc. Like, you know, but it was making self-management become mainstream in primary care. And so we had to go, and we went into the prisons, we went to the traveling community, all different types of communities, etc. Black and Asian community, Chinese community. That was our remit. It was to make it mainstream. And for one reason or another, which I won't go into now because it winds me up a bit. But we got managed by plonkers as well, I suppose, a nice way of putting it. And we sort of fell off a cliff, etc. But I think I feel like there's another surge coming along, a new wave, and I see a lot of healthcare professionals are now getting involved in the coaching side of it and coaching self-management. But for me, it's about tonight is about if we can discuss it, how are we going to get in there? But what are we going to be known for? Because I think us lot, we're making history. And what I think is, how do we want to be remembered? For making history, not because we didn't do it, but what are we gonna do? What's going to be our footprint that we can leave behind, and saying that we was part of that. And I think I've had a bit of wind in myself tonight. I was talking to I can't remember, Alex Chisholm from Canada, and she posted something over there they're doing in Alberta where people can actually self-refer themselves to a self-management program, albeit it's online. And so the doctors can refer the patients to it. I did ask her, say, is there a waiting list, etc. But that to me, what a nice way to end the week, like, hearing that there is something going on. And that, I mean, I don't know how big Alberta is. Is that a big province in Canada? So that to me is getting it into mainstream healthcare, etc. So, but what can we do? What can we discuss tonight? What ways do you think we can get supported pain self-management into the community, make it mainstream? Okay, so over to you guys.
There's a hand up, Peter.
Yeah, go for it. Sorry, I was
That's right.
Virginia.
I figure I'd get things going, and I've heard about what Alberta's doing. They've got an Alberta pain strategy, and I've talked to them about what they're doing and their self-management. I think really what we can do is not miss a moment to talk about it and bring it up. I mean, I've internationally talked about, like, our peer support groups are about pain, self-management, education, and we've talked about it. And Mary and I have done talks international about it, what it offers, what it is. We'll be speaking to the Canadian Pain Society about it, and it's about peer support, and it's about the self-management, and it's in our communities. But you get people like us who are put in our communities, and we've been doing this for a decade now. How do we get clinicians to embrace what we're doing in our communities? Because, we really can't miss it a moment on this. And one thing we've done with Pain Canada, they have is Making Sense of Pain program, which is, I think, an 8 or 10 week program. But under Pain Canada, they'll move it into other provinces. So what I've been doing is letting clinicians know from other provinces, you have an opportunity here to do this, that they'll support it, they'll support financing. So really, it is, don't miss a moment when you see someone, to share about it, talk about it, and share about what others are doing, and build alliances to what we're doing.
Thanks, Virginia. I think next, Susan, you think you had your hand up next?
I did it again. Now I'm unmuted. That was brilliant, and I forgot what I said. Anyway, yeah, Virginia, thanks for that. That's bang on. I think that's something that we can all do. I love that. I think Pete, something you had said as well. It's the management. I had a program where it was 1 to 2 years to see a doctor, so we started a self-management program as a first step, and it was highly successful. And we were a tertiary clinic. And so the people that came to us failed every other conservative measure. So they would come, they'd have a little bit of pain science, a little bit of self-management, and they'd be on their own. And when it came time to phone them for appointments, these very people, like I said, who failed everything, just those things alone, 2 out of 20, so 10% said they didn't need a physician anymore. That's huge. And so I think when we talk about it, we need to talk about, talk about it the way that the people need to hear it. So the managers, I think that's going to be a big one. And that's kind of what wrecked the program that I was in, was a manager coming in. So we need support from managers, but we need to talk the talk. That's huge cost savings if we can get people, not seeing the physicians who don't need it. We need to talk about that kind of, that piece of it, how it can benefit them, not just how it can benefit the people in pain. Yeah.
Thanks, Susan. Mary?
Yeah, I was going to say the same thing. I also run support groups, the Adelaide Pain Support Network here, and we teach it there, but that's only such a small thing compared to what we need to do, although we can hope that the people who are learning from us are going and spreading the word to other people. Our public pain clinics here in South Australia, I can't speak for the rest of the country, but they teach it fairly well. But outside of that, it's basically non-existent. It's all right, I saw a message at the bottom of the screen there. It's basically non-existent. There are a couple of programs, but I think there needs to be more, and I think Virginia's idea is brilliant. The more that we can talk about it, the more that we can talk to everyone that we talk to. That's basically the way to spread the word, I think. And I can't think of any other way that we can get it out there, because it used to be here in a bigger way and it was very successful.
Thanks, Mary. Helen?
Yeah, I think like anything in the pain care world, the approach is going to be multi-pronged, multifaceted. Coming back to what Virginia was saying, I just think there's going to be big changes needed and small changes needed. So I've been thinking recently about the context in which supporting self-management thrives, because the reality is in my own little practice, I might be supporting self-management, teaching it, speaking about it, but I'm still sending people out there into a very biomedical framework, which doesn't support self-management, because if people are still believing inaccurate information about pain, they're going to go, well, how does self-management work when I actually need a pill? I need surgery. I need, all this stuff. So I think there's people here that have said they're involved in sort of undergraduate training and pain education. So I think one aspect is looking at this context of training practitioners and the context in which people are receiving healthcare and saying, we still need the basic stuff like pain education to support self-management. But then we need each practitioner to also be doing the smaller bit and promoting it. So it's big and small stuff at the same time, as far as I can see.
Okay, thanks, Helen. Hem?
Kia ora everyone. Yeah, my name is Him, joining from Wellington, New Zealand today. I did go for a run this morning, and I was actually thinking about the meeting today in terms of what are we gonna say and what am I gonna learn from everyone. So I think the elephant in the room for me is the sort of the crux of the supported self-management is it's a shift from the medical model to more a collaborative shared decision-making sort of model. So which means the power sharing and I think until the clinicians realize that the power needs to be shared, there is expertise of this person in front of me, and therefore what can I learn from them, and then so that I can understand this person's life a bit better so that I can be supporting them in this journey. And I think for me, I think that's the fundamental thing. No matter where you are in the continuum, like your primary care, tertiary care, public setting, private setting, if that sort of cognitive shift from a clinician perspective, like that sort of power shift, like, okay, I'm not here to sort of save this patient, or like to say rather, okay, let's hear this person's story. Let's see where I can be of any help and support this person in terms of what they want to do, what they want to achieve. So I think for me, I think that is more a cognitive shift for supported self-management to become integrated and mainstream. So I have a few other things, but this is my first round, so I'll keep quiet.
That's fine. Dermot?
Pete, thank you for allowing me to join your audience. I've been in pain now for a very long time, pain medicine for a very long time, and largely it's in tertiary care, so sort of quite significant disease processes present to us. Having said that, I'll take any opportunity to speak with primary care physicians, allied health in the community, and that has been very effective over a long number of years. We also have the medical students. And one of the things that I would like to emphasize is really we should use some of the skills that they already have in managing chronic obstructive airways disease or diabetes or ulcerative colitis or even epilepsy, that largely that is done by the patients themselves, by their carers in the community, with some advice intermittently from doctors, specialist nurses, allied health, etc. But so there's lots of skills out there that we just have to tap into that are used in other areas. And pain medicine, pain management, self-management of pain can use many of the techniques that are used in that: motivational interviewing, goal setting, all the usual ones that say a diabetic uses. And happily, in the last sort of 10 or 15 years, I've noticed that our neurosurgical colleagues, our orthopedic colleagues, our plastic surgery colleagues are much more willing, and significantly more willing, very noticeably, saying to us, asking us to see a patient and more or less saying, tell me why I shouldn't operate on this patient. And do you have an alternative? Because obviously a mechanic will mechanic, a surgeon will surgeon. And you know, if they don't have the tools, they'll just use what they have. But if they have the knowledge that there may be other people out there, that's useful. So I'm not quite as bleak as possibly I used to be maybe 10 or 15 years ago. There is the knowledge seeping, not gushing, but seeping out into the community. And you're right, talking about it is very important. I have some problems with some of the, shall we say, Facebook groups or the self-directed groups that get together, because sometimes they can go off in one direction which may not be as useful. So it would be useful to have you know, skilled allied health doctors, skilled nursing staff to sort of not so much direct it, but just to keep an oversight on the process and you know, manage shepherd the process through.
Okay, thanks. Sorry, Susan, gotcha. You're on mute again. You muted
Yeah.
again.
I'm so good at that. It's like the habits and the routines that we need to teach people with pain, right? Like I've got them ingrained, not the good ones. It's curious to me that you know, I think I'm not sure if it was when Hem was talking or is that, you know, yeah, absolutely. People with pain are the experts, and I've learned the most from them. And I think I think I lost my train of thought there for a second. It's interesting that the people here, like we're all doing it and we're all having effect and we're all supporters of it. How do we get to the people who aren't supporters of it or don't understand how, like, you know, it'd be interesting to talk to the people who aren't even maybe aware, to find out where's the gap, because we're doing it. Sort of, we're the success stories in our sort of like what Mary said, in our own little way. We have our own bits that we're doing, but how do we get to the people who don't know, and who are they? Are they the hospital people, the administrators? Are they the business owners? I don't know. Just
The
curious.
decision, I think it's the decision makers that they're the commissioners and people like that, and especially the medical schools, because there's, you know, when I see healthcare professionals post stuff on social media, etc. And it's like, and I'm thinking, so, well, hang on a minute, we were sort of talking about that 20 plus years ago, but I forget, you know, I have to remind myself that the people that are coming through the medical schools are still, you know, they're not taught sort of, you know, certain information. So, you know, for me, it's a bit of an old drum I have to keep banging. The medical schools need to be adding, you know, within their curriculums, like, you know, a self-management model, at least, like, you know. And well, I think we all know, from what I'm told anyway, I think it varies in different countries, that medical schools, when doctors are in training, I think it ranges from doctors only having like 19 hours to 23 hours in 5 or 6 years of about pain management, etc. You know, and I always remember I can't remember the name. He used to be the president of the European Pain Federation, Belgian fella, and he always remembers, you know, him saying at a conference once that a vet receives more training in pain management than a doctor, like, you know. So there's this, you know, we've still got these discrepancies, and I think what also come up for me this week as well, like, you know, because especially here, and I'm guessing it's like that in around the world as well, waiting lists. You know, people are, you know, here at the NHS, we know we're in a pickle bit, but, you know, to put it politely, you know, and people are waiting a year, 18 months to see someone, and look, in some areas for certain problems, it could be more than a longer time. So I'm thinking to myself, well, why? You see, I ask these things on social media, and I've got to be honest with you, the feedback I get is bordered on zero, really, because, and it's not, I don't blame people. I'm not looking for everybody's got to give me an answer, but because I think well, what do we do if I don't know what to do? But why, while people are waiting to see a healthcare professional, why can't they do some sort of self-management learning while they're waiting? Or, I mean, me and Keith, we put together a toolkit last year, was it the year before last, a prehab pain toolkit. So it's something. So instead of waiting waiting for something, they can actually learn about what they can do for themselves prior to an operation or treatment, etc. So for me, I don't know. Perhaps I'm looking at it too simplistically, but for me, I think why aren't we doing it? It just seems to be common sense, and yet it seems to be. It's like try, trying to shift a mountain sort of thing, and I'm more constantly talking to like the health ministers, like shadow health ministers and the health minister. I mean, I contact them, and I know I'll never get responses, etc. But because I don't think no one knows what to do. Like they can't, they're just stuck. And I think if we're waiting for them to come up with the answers, then I think we're going to be really in problems, be in real problems. So I think in a way, this is why we've got to come up with solutions. Like to me, it's like I learned years ago that if you want to put something in the newspaper, you've got to learn to write a press release because you're giving someone an extra job to do. But if you learn how to write a press release, all they need to do, you find out when the deadline date is, ship it into them, get it into them. Oh, yeah, this is right, bang, and it goes in the paper, sort of thing, So I think if we're waiting for people to come up with the solutions, we're going to have a very, very long wait. So really, and that's one of the things that went, like the other group, the first guys we was in the conversation with Jerry and co, Bronny and whatnot, Toby, where we put that proposal into the World Health Organization, and I know it's being seen that proposal is now being seen by IASP, the International Association for the Study of Pain, and also another guy associated to the World Health Organization that talks to GPs. We're still waiting for them to come back with some feedback, etc. But to me, does it need to be grown from the grassroots upwards or top down? I don't know, or perhaps it needs to be a balance. But to me, it's about and tonight, as I say, it's about how do we shift things? How do we get a ball rolling? But we need to make it simplistic. So when we approach the decision makers, it's not like, oh my God, this is a lot to take on board. Perhaps we have to simplify it so much so that they're thinking, well, this isn't a big deal. Perhaps we can do this. Sorry, I've gone on too long there. Virginia.
Thanks, Pete. You touched on so many wonderful things, and I think a lot of it is, how do we get them past that part? And like I said, the medical model is not change in self-management, and I think that's a big thing. But I think what happens with organizations like what I run is the medical model is also fearful to send people or refer them to our organizations because of fear. And it's been said here tonight, you don't know what these Facebook pages have and what they're doing. So it becomes up to us to let them know that, especially with us in Canada, we have about 4 organizations which are about peer support that our facilitators are trained. They have competencies they have to make. They have evidence-based materials they use. So that way, if we build that sort of a model, we're going to get more of a buy-in from the clinicians, but it's still getting them educated that this is what we're offering, because they don't want to send because they don't know a lot about self-management, that they don't want to send their patients down another rabbit hole either. So it's really about building that. And the more you get the word about the pain toolkit and the People in Pain Network, really that's a foundation. What we do is the pain toolkit, that self-management, it really helps what we do too.
Dermot, can I go to Seb first and I'll come back to you in a minute? I'm going to give him a go. Seb.
All right. I got so much running through my head right now, so I'm hoping I can produce one coherent thing here. But you know, I think it's something that's been touched on a few times here, and you know, working in both the public setting and the private setting is very interesting because I see two very different constraints that happen. In the public setting, like I think Pete, you kind of mentioned, you know, and obviously I'm 100% with you on this. You know, while people are waiting, there's this very long wait list to go to pain clinics. They should be doing being educated about supported self-management. That should be brought up with you know, the primary care physicians, allied health professionals, whoever's referring. But what I see almost on a daily basis is this kind of other thing where it's like, okay, nothing's worked. You just got to hold out until you get, like, wait the however many months until you get to that, you know, that appointment, and then there's so much pressure on that appointment in the public healthcare system, and then there's so much pressures on you know, the physicians, and you want to solve something right away, and you know, despite the point of view I have, it's something that I feel every day, and it's a tough situation, and you know, it's really hard to navigate. And the other thing I'll just say, I don't want to take too much time, but something I struggle with, and Pete, I talked to you about this briefly when we first met, is being a healthcare professional who's really passionate about helping people with chronic pain, just the way I've seen people in my life who I really care about suffer with it. It's really hard to talk about self-management sometimes without feeling like a hypocrite, or like, you know, you can't put them in your shoes. You can try and imagine, but you don't know if you'll ever be accurate with your imagination. You know, there's that kind of, I personally feel a lot of hesitancy. I want to say the right thing, and sometimes, you know, I don't know if it comes across right now. I feel like other healthcare professionals might feel the same way. Anyways, I rambled on there, so sorry. Hopefully one of those things is coherent.
Okay, thanks, Seb. Dermot.
Sebastian, I just through Pete, Sebastian, you're going to say the wrong thing so many times, and I've done it down through the years. So don't worry about that. I look, the evidence is in the literature about short sessions. Beth Darnell has done an awful lot of work on this. Years ago, there was a program over in Western Australia for patients who were referred to a pain unit, that they would do what's called the STEPS program. And certainly people in Australia would know about it. And when we investigated it, we renamed it because for our environment, we had to change it. And that's why I think we have to evolve from the bottom up largely, because there's so many different conditions in different areas. So we progressed through to 2 sessions called the MAP and Compass, and the MAP was to look to see what the environment was like, and the Compass was to navigate your way through that environment, and that progressed through to the pain management program proper, where you picked up various different skills on your tool belt, as we called it then, a toolkit, if you like. So you know, there are local things that need to be taken into consideration, and so you know, one program is not going to look exactly like the other, even if the principles are exactly the same. But the science is out there. The guys in Stanford, and Beth Darnell, who I have huge respect for, she's a professor of psychology, pain psychology at Stanford, and you know, on single sessions online can be pivotal in the journey of patients with pain, even when they have failed other treatments. And in actual fact, we shouldn't even use that language. We should say the treatments have failed the patient rather than they have failed the treatment. The patients haven't failed anything. So the language that we use, and then just stepping to the side, using that language and skilling people up in that language, with medical students or registrars and specialist pain medicine physicians in training. They need to understand the nuances of language and communication, even to the point where you set out the office in which you're consulting the patients and have things within arm's reach to get that message out. Because if you have a successful patient, they'll tell their family, that'll go down to the local club, etc. And so bottom up can be in various different techniques.
Yeah. Thanks, Dermot. Helen?
So I think if I was going to put this in different language, I would say what we're trying to do here is sell a good product. We're selling a product called supporting self-management. And when you want to sell something, you've got to think about who you're selling it to. So it's one thing for us to sell supported self-management to people living with pain. It's another thing to sell it to the healthcare fraternity. And I think Virginia was touching on the attitudes that we sometimes met with. There might be fear, there's defensiveness. So I think one of the things for us to think about is how do we sell this? Like, how do we say to other clinicians, you need this too? What's in it for you? I'm putting this in very basic human terms. You know, people always think, what's in it for me? People are not as altruistic as we would like them to be, or we hope they will be. So what is in it for healthcare practitioners? We know what's in it for people living with pain. So how do we sell this, and how do we not run up against a wall of defensiveness and fear, and how do we invite collaboration and welcome it, and not be aggressive about this and bashing healthcare practitioners over the head about doing it wrong, or you know, those kind of ideas.
Thanks, Helen. Dave?
Yes, just thinking about it from the patient's point of view, because this is the journey I went through about 5 years ago. It's you get so used to, as you're growing up, that the medical model is going to solve all of your problems for you. If the GP or whoever suddenly turns around and goes, we can't do anything for you, go off to this community, and they're going to solve world hunger and everything else for you. There's a wider education thing there, and I think somebody mentioned about the different audiences, selling it for healthcare professionals versus selling it to patients. There's got to be some messaging around medication, or the medical model is not going to solve everything, and this will make your life better, rather than we've run out of things we can do and therefore you need to go here. Someone earlier, and I forgot who it was, said, they've got colleagues coming along and saying, why shouldn't we operate? So it's the same thing without before you get to the operation, why shouldn't we medicate? What should we do instead? What are the alternatives? But you need both sides of both the patients and the healthcare professionals to accept that, or be educated about it, before we'll make significant progress, I think.
Okay, thanks, Dave. Jerry?
Yeah, man, everybody, I think, it's interesting to me sitting back, and I'm not just typing in the chat, you taking notes. I think everybody has brought everything together here. Seriously, I think everything everybody has brought up is so much of what needs to be considered. And here's my takeaway and my viewpoint on this. In this bottom up idea, by the way, if I hear bottom up, I think the people outside the system. And him brought up a great point that really drives this home. And I think success comes from, and again, everybody has said this, so I guess I'm probably just repeating so I understand it better. Success comes from, actually, I would argue, them driving this. And here I'm going to say this out loud, that we possibly don't need the current system and the current medical people in the conversation yet. Yes, they have to come in, and yes, I get it. And yes, we need to coordinate this. Yet, what I have found over time, and Sue was the first one who said this, what I found over time is we've got to take the individual stakeholders, the money side, right? Some places it's different. But if we take the people being served, the patients, and maybe take them first because they went through the system, Dave, right, which you just alluded to. Take people who went through the current system, get their feedback, what was good, what was bad, right? And start building from there, but then go back down to the bottom and start educating the people about, and I heard this, so I'm sorry, I can't credit it, but then let people know that the world is not about entering the system first. And I'm spending a lot of my time and energy on this. And fortunately, I brought it up last time. The paper I put together with a couple of other people, it's an opinion paper, but it's getting published. And it's about nocebo and the whole of healthcare, not just the providers. So this idea of educating the public, because this is where I'm spending all my time. How do I get farther upstream to get a call from someone who has back pain and literally with the goal of keeping them out of the system? Now doing what's best for them. But we know if we read most of the research, if we keep them out of the system, then it's what's best for people. And then if the education and the process is set up around that, then I believe we get back to your question, Him, that you put, that I responded to in the chat, that we start to engage other people who don't have access to this system. So I just want to put that all out there because if we get all the stakeholders, we figure out who we're selling to. That was Helen said that, yeah, which is exactly right. We're selling to the providers, the people, and then we got to go to the payers. I've been spending a lot of time on the payer side to hear what is their incentive, because I'm trying to figure out how can we finally tap them in to go, hey, Pete, your self-management program is actually the best thing we've ever seen. And we're going to make you part of our program, because you and I, we all know here, people are going to follow the money. So when that money side agrees that Pete, your self-management is the right idea. So again, different stakeholder, different conversation. So I'm going to stop talking about 5 seconds, but different stakeholder, different conversation. What is your incentive? What drives you? Me, right? And then we make some progress.
So I'll come to you a minute.
There's my $1.50 in US dollars.
Thanks, Jerry. So I'll come to you a minute because what Jerry just said there. When we were going back to the expert patients program that we started up in 2001, and we were so new. We had to be quite innovative ourselves. But I knew because I've had dealings with researchers and healthcare professionals, I knew from the get-go that I had to. When we started running these courses, what's in it for the primary care trusts, as they were then, for them to take it on board and to invest money into it, etc., invest their time and signpost people to it. And so what I put together, I was started doing research myself, but it was I adapted some of the questions that kept it nice and simple, so patients all they had to do was circle 1 to 10, etc. Kept it. But there was 2 things I added to it. So it really, in a way, it wasn't a validated paper because I mucked about was the 2 questions. But the 2 questions I was really interested in because I knew these 2 questions will be the ones that the commissioners would really take on board. And so the questions were, since going on the program, since doing a 6-week course, as your need to see a healthcare professional, a GP, or go to an A&E visit, has it reduced? And they had to put reduced by. And since coming, of course, as your is your need to take medication, is that reduced, or have you had a medication review? And the amount of people that tick the boxes. So even before we started doing a national evaluation of the course, we were doing it. And that was the bit, when it comes to the bit of selling the idea to, then they were called primary care groups, primary care trusts. These, where they worked in little pockets and whatnot around the Essex area where it was the county that I was in charge of. I had the evidence there that by people going on this simple 6-week course, that they were feeling better about managing, they're more confident about managing their health condition. But more importantly, their need to rely on healthcare services had reduced. and I knew that that was the key factor. So I think again, as Jerry says, it all comes back down to the money sort of side of it. Will it reduce GP time, healthcare professional time, resources, etc. Like, you know, and I think that's the only way we're gonna get the decision makers, their commissioners, or the decision makers, not only in healthcare but also in social care, because social care, as you know, help. You know, when people have had pain for longer than 3 months, you know, other problems kick in like money worries and relationship stuff and all that other business, and so, you know, they may have to rely on more social care. So to me, it's about knitting those together. So it's also getting social care involved, but showing to them that by promoting more self-management, it's not such a burden on them, you know, because this is why we've got all these massive waiting lists, because it's the healthcare system. It makes people, it's a nurturing service, you know, and stops people, as it did to me and many other people, it stops us thinking for ourselves, you know, it's we get anchored into it. So it's how do we, well, it's getting into those decision makers, but I think whatever programs we're running locally, we need to evaluate it, show that it can save money, resources, etc. So I've got on too long now. Sorry, Seb.
All good, Pete. That was all yeah, all good information, and that just got me thinking about some other stuff as you were talking. And also in the chat, I think it was Jerry mentioned talking about like things needing to happen in parallel. And the idea that kind of sprung to my mind was like, how great would it be, and how much pressure might it take off healthcare professionals if you know, a patient with chronic pain presented, and then, you know, the awareness about the importance of self-management first is so prevalent, where saying to a patient like, hey, let's have a conversation about what self-supported self-management looks like, that if that wasn't a shock to the patient that you said that, right? How great would that be? But then, as I mentioned before, public constraints of the public healthcare system, if you say that to a patient who's been waiting 6 months currently, that's sometimes a really difficult conversation to have. And just that's just my perspective of things. So, you know, absolutely doing things parallelly, working towards the clinicians, creating awareness for the public and people in pain. It all has to be done at the same time.
Thanks, Seb. Hem, I think you were next.
Yeah, thanks, Pete. I've been just want to sort of reiterate all the great points made in terms of how do we have these sort of different conversations with different stakeholders, because ultimately there's so many sort of stakeholders involved, and yeah, I'm very biased here, so I'm always thinking about the people that we don't see in the health system, and probably due to historical reasons, and yeah, thinking about people who are indigenous or ethnic minorities, or people who really even find the health system triggering, or quite confronting, or are not helpful in a way. So, but we call them lack of health literacy or poor health literacy. But I would like to reframe it to say our health system is not structured enough to make everyone health literate. So so in a way, I think even I don't know what self-management would look like for those communities. I would say, hand on my heart, even pain research is not there in terms of listening to their voices, understanding what they're doing. And there's so much strengths out there, like the way they work for the communities. There's so much that we can learn that can make this supported self-management even more holistic. Like what you were saying, Pete, like it's not only health and social care. For example, like in New Zealand, Maori, the indigenous population of New Zealand, they work a framework called Whānau Ora. Whānau means individual plus family and significant others. Ora means well-being. So they not only look after the individual, but also whoever they think as a trusted person, not only biological, but extended significant others, and they look at more things collectively, and not only look after health, but also social and other aspects as well. So so the communities, there's a lot of strengths that where we can learn, and we can like even make this whatever our understanding of supported self-management even more holistic, so that it when we hear this word, that it resonates with everyone, not only like specific groups of people. So that's my $1.55, Jerry.
Thanks, Em. Helen?
So I think I'm following a similar train of thought to you, Hem, in that to take this context of what kind of context does self-management thrive in, even bigger, I'm thinking societally as well, and thinking here in our nation of South Africa, we still have people in our nation who are learning that they have basic human rights. And for me, self-management is an issue of autonomy. And I actually teach it in the context of ethics. So I've got a workshop coming up where I'm talking about self-management as an ethical imperative that healthcare practitioners support. So this is not necessarily helping us be practical tonight, but I'm just kind of putting it even in that bigger context and saying this is a justice issue. This is an ethical issue. It's an issue of autonomy. And so it's almost got to be in policy much bigger even than healthcare. But it needs to filter all the way through down to that one person in front of us in the consultation room. So it's huge. And I don't want us to be overwhelmed by that, but it's just we've got to have this multi-pronged policy, clinical, education, all of it together. I think I'm just so aware of that tonight, listening to us talking about this.
Yeah. Thanks, Helen. Mary?
Yeah, look, I agree with what everyone's saying. I think that education is so key here. And it needs to be, I'd like to go back as far as schools, to be honest, but the people who really don't know anything about any of this are politicians. Because even if you come up with the most wonderful thing in the whole world and you get all your school children taught and all the rest of it, the politicians still won't get it. It's pain, you can't see it. And this is where the issue lies. For example, I had a lady that I was talking to. She was very keen to come and join one of our groups, which, by the way, are educational as well as being support groups. And she was quite keen, and she was keen for a long time, and she was still keen. And then right at the end, she sort of said, this was a messenger conversation. She said, gee, I'm not really sure if I'm ready to live pain just yet. And, it was 20 years. So she still 20 years later thinks there's a magic bullet out there. And there are so many people who still think there's a magic bullet. Even some people who are going through pain clinics are still thinking that they will be cured by the time they come out. And yet the pain clinics are teaching them self-management. So it's a very difficult area to get across to people. And I think it's because we go right back to when we were children and we scraped our knee and we put a Band-Aid on it. Or if we did something more serious like break our arm, we went to the doctor and it got fixed. And I think that's a very hard mindset to shift. And as those of us who live with chronic pain would know, it is a very difficult thing to come to terms with, that you will have it probably for the rest of your life. Some people are lucky and they do actually manage to come past there, but they're always at threat of relapse. I find the people that I know that have done very, very well can still have a relapse if they're not careful and they don't, abide by their self-management strategies. And no, I don't have a solution to the politicians. I'm sorry.
Yeah, politicians are tricky. I'd like to mention their ones here, but I won't. Oh,
They've got the money.
Well, no, they're taking it from us. There's been a lot of I don't know if people have been watching the chat. There's been some fantastic chat tonight about this subject. I mean, it is a massive problem. We perhaps we're starting things off here because I don't know if you remember the last conference we did in February. Something come out of that. Do you remember the guy Peter Stilwell from Canada who's moved to Denmark? And he sent me an email today, and someone had watched that webinar because Peter was speaking about the walk and talk concept, where there was, people with pain gut just taking them for walks, they're all chatting about stuff and whatnot. And I think it's a lady in Argentina. She started up a walk and talk group based on that, and it contacted Peter. I mean, so hopefully, it's amazing how things start from, and I think, today, tonight or today, this morning, wherever you are, these are conversations that we need to be chatting about because we need to swap some ideas. I mean, I learned from the work that Helen does down here in New Zealand, where he's actually engaging community people, the community itself, and promoting their self-management message. Dermot.
Thanks, Pete. This is going to be my last point because I need to be offshore in about half an hour. I think sorry, another call coming in. Look, there's a lot to be depressed about in this space, but there's actually a lot to be to rejoice in terms of the progress that's been made over the last number of years. The point was made that we want to have a solution and and a resolution of pain in individuals and in groups. And when I trained actually in Adelaide for Helen, and I used to say to the patients, I don't have a magic wand, and the nurses in the unit actually bought me a Barbie pink magic wand with glitter and things on it, and it still sits on my desk. All the glitter has fallen off, and I have an out of order sticker on it. So but look at the obesity management sector. We're just looking for a very simple way of medicating that away, when I mean it's just absolutely tedious, the solution to that, and that's diet and exercise, and it's absolutely tedious. But and the self-management in pain can be tedious because there's no mention of absolute resolution, and self-management is just that. It is managing the situation yourself and using all the techniques that we know about. So look, from this conversation this morning, I'm quite actually uplifted by it, and that there is a groundswell of opinion in the community. So I'm going to exit the meeting at this stage and put on my life jacket and get offshore. And thank you very much, Pete, for joining me. And I really enjoyed all the comments from across the world. So well done. Thank you.
Well done. See you again. Take care, Dermot.
Take care. Bye.
I know, Helen, you've got to go soon, have you? Yeah. Helen's going to be, tuck yourself up in the bed. Just say, go for it. I like it. You just whiz off whenever you want to, Helen. You haven't got to raise your hand and say, I'm going now, right? But just say, we know that you are.
Well, I'm enjoying this so much, I might stick around a bit longer.
Oh, well.
And now I'm wide awake.
I'm glad you're sticking around. And Seb, over to you, Seb.
Yeah. One thing I'd like to know from each of you, and maybe we could talk about this now or even like in an email thread later on. And I asked this selfishly, and hopefully other clinicians watching this, hopefully this video gets 5 million views and reaches a lot of people. To the people in this meeting who have persistent pain, what I'd like to know from you is what's something you would like the healthcare professional to know, or something to consider before they bring up supported self-management with you, so we can reduce the barriers and the pressures they feel as they do it. And then to the clinicians who have more experience than I do, as I said, I just graduated in June. based on your experiences of bringing up on this conversation, what advice would you have for your fellow clinicians regarding how to have this conversation?
What you actually what was the key messages you want the healthcare professional to talk to them about?
So, sorry, what's that, Pete?
So, like, what's the key messages you want to hear from the healthcare professional?
Yes. So what I want to know, like from the people who have persistent pain, like what would you want your health professional to consider, or something about, when they approach the bringing up supported self-management, what would you like them to be thinking about or be mindful of, and how to approach it? And then from the fellow clinicians, if they have strategies to make that conversation easier. I don't know if that makes sense. Yeah.
Susan, you've got your hand. Him still plugging himself in. Susan, what was you got your hand up there?
I think that's an excellent question. And my my second voyage into pain was at the clinic I mentioned, a tertiary pain clinic. And I did that self-management talk to over 10,000 people. So I had quite a lot of experience in failing. But I'd love to hear what people in pain, what their experience is. I think from my perspective, you have to give them hope, right? I think that's going to be really, really important. And also you have to honor whatever reason they have the pain. I think that's a really big one, because if you are, I think a lot of people, or perhaps what I've done wrong initially, hopefully I've learned, is I was so excited about the neuroplasticity and so excited about self-management that you'd go on about it. But they're like, yeah, but I got hit by a bus. Like I've got, A, B, and C. So I think, I think you want to sort of separate those two and say, yes, these are both, we can hold these both together. Yes, this happened. And yes, maybe we will or won't find a diagnosis, because you have to meet them where they are. So they might still be looking for that magic something. And also, let's look at doing this bit here, because what we know is that if you've had pain longer than a certain time, your nervous system's involved. So let's work with that, with your self-management stuff. So those are some of the big things that I've found. Meet them where they are, believe them what they say. Definitely give them hope and say, this is a thing. It's not, it might not be everything. And because we don't know, it could be everything for them. But yeah, give them a piece. But I'd really love to hear from the people with lived experience, either what we've done wrong as clinicians, furthermore to Seb's question, and what maybe we could do better. Yeah, thanks.
Thanks, Susan. Hem?
Yeah, I think great points. What I was going to say was, what I do, in terms of spreading the word of self-management is, so we do run group pain management programs, and I sort of deliberately look out for people who we don't see, like so once they sort of go through the program and they become like their own sort of champions, and they have this realization, right? Like, because that's the bit about self-management. Like, it's not like you can get it like in a one meeting, like, or in a 30-minute consult. So it takes time, because people's pain experience journey is so many years, and to expect them to understand this idea in however minutes is unrealistic. So therefore, it takes time. And for the people who got this through the program, I deliberately encourage them to be their own sort of community champions, because if they go and be the sort of the cheerleaders and peer supporters in their own community, then that's how that is a more powerful way of actually getting the word around. And I've been sort of deliberately doing it. Because if we see a Maori patient, if I see a Pacifica patient, if I see a refugee patient who because we don't even see, their referrals are so low, and the number of people who get referred to a pain program is even lower. And by the time they finish this 12-week program, the numbers is very low. So, but the people that we get, it comes down to like single digits. how do we sort of nurture them, support them to go back to the community and still yeah, because I mean, yeah, I can't be there everywhere, but if they can spread the word, that's more powerful, and they have the mana, the prestige in their community. So yeah, those are some things that I do to, like yeah, I mean, for me, I feel like the changing clinicians' behaviors are the hardest. So I'll leave it to other people, but rather I'll yeah, thank you.
Thanks, Hem. And Dave?
Yeah, so from the patient's point of view, it's a tough one because when you're growing up, you're taught that the doctors know best, and you're almost told not to challenge them because they're these mythical people that have got all of this knowledge, and you're just the layperson. What would you know? So, sort of breaking down that image that you can't challenge them, and which is hard because you're in pain, and as a result of being in pain, you just want someone to take it away. And if someone turns around to you and says, hey, the medication I've got is not going to take your pain away, but this other thing might make your life better, because we can't say it will because there's no definitives. It's highly likely to, based on my experience and experience of others. So I don't actually know what I'd want them to say, because it took me 4 or 5 years after I went through the NHS version of the pain management program before I came to the Pain Toolkit, and actually started to take control of my life. And that was because I'd had enough. But until such time as you've had enough and you're in the right headspace, it's going to be very hard for an untrusted healthcare professional to be able to get you to go down that journey, because we don't have in the UK at the moment the ability to see the same GP for more than one appointment in a row. So you don't build up that relationship. So I don't have an answer, but I just thought I'd share the perspective.
Mary? Thanks, Dave.
Following on from what someone just said a minute ago, because I was writing, so I just heard it come in, about learning in groups, or what might have been in the chat. Excellent idea, because as Virginia would know and has seen, the peer support, it makes it just so much more powerful, because people learn from each other, they coach each other, they help each other along. I have seen some awesome things come out of people who weren't able to do something. All of a sudden they can, because a group has encouraged them to make a plan, to try it, to give it a go. And, if I had time and we had time, I could tell you some pretty amazing stories. So I think that is the way to go with education of at the patient level. And I just see no reason at all why that can't be done, just as it used to be with your expert patients program, with the Stanford program, with trained facilitators who are people who already have chronic pain, because that they also get it. And then the people who come to those groups feel more at ease the minute they walk through the door. But you need to train those people. Obviously, our facilitators in our support groups are all trained. So along those same kind of lines, we take the topics that we train along the same kind of lines that I was talking about with expert patients, Stanford, etc., and they're all trained. And we also do a course with our Lifeline, what we call our Lifeline organisation over here, which teaches people what to do, where to steer people, and how to manage anyone who may be having some rather dangerous thoughts, because that has actually happened as well. So we're well covered there.
Thanks, Mary. Helen?
Just some last thoughts for Sebastian. Something I sometimes do as well is usually when someone's had chronic pain for a long time, they've got a lot of nociplastic pain, where first line management is all non-pharmacological. So often I will just present the evidence that some of the best options available are non-pharmacological and fall into the self-management category. So actually using the evidence as well to support the argument. But often, like Dave mentioned, people I'm working with have been through the mill, seen everybody, done it all, and they've run out of options, and then they get to self-management, which shouldn't be the case, but it's often then when the person might be ready to accept that. Yeah.
I think just sitting here thinking, you know, there's like very strong parallel always. I think I've said to you before, I used to be a driving instructor back in the day. I had hair then as well. And it's like it's having that conversation, you know, when I was teaching people to drive, it was about communication and confidence, etc. And sometimes it's not so much about saying, it's talking, it's the listening bit. You know, why do you want to learn to drive? You know, and a lot of people want to or have to learn to drive because of not because they want to, like, you know, because they have to. It's more, to me. It's I always say to people from the get go. You know, what how do we, you know, do you want? It's all about getting yourself back in the driving seat. How do you think you need to do that? You know, because I think it's not about setting yourself up as the expert, because people are already experts at doing stuff, like, you know, it's just that we'll be switched off. People with pain or long-term conditions, you know, so it goes back to being where we are nurtured, you know, because the medical model takes over and stuff like that. But the thing is, the medical model's fantastic for lots of health conditions, but for a lot of, you know, for us with pain, it's like it's as much good as having a third eyebrow. You know, it ain't, you know, it's you know, for some painful conditions, you know, maybe where people may need some need medication, but you know, for majority, I think the people that I've spoken to over the years is that self-management it's an experience. You know, I think I said that this week on social media. You know, it's not you know, we should call it a doing thing. Yeah, you've got to do something. You know, it's like saying, dear Arnold Schwarzenegger, I've read your book. Now send me the muscles. You know, if you want to look like Arnold, then you've got to put in the work as well. Like, you know, so it's a doing thing. But the doing thing, you've got to make it fun, you know, interesting. You know, it's what we changed the people, we now call it meaningful movement rather than, you know, exercise. For a lot of people, you know, oh God, exercise, oh bloody hell, mate. You know, but I mean, when I heard that phrase, I was old school, see, I was thinking, no, exercise, get off your butt and do something, you know. But the thing is, I go down the gym, but I only do the stuff that I really like doing, you know. Now go on the hamster wheel, but I ain't on there for hours. I just get on there for 5 minutes, but go and do some weights and do some bit of yoga and Tai Chi. I have fun down there, I chat with people and whatnot, like, you know. I was making it a nice experience, you know. When I've just, since before Christmas, I've started going out at lunchtime, doing some walking and stuff like that. And when there's some nice places where I walk, it's very in the country, so I listen to the nature and whatnot. And when I'm doing some road work, I plug myself in and listen to Planet Rock Radio, you know. But so it's not a chore, you know. But I know, and since I've been doing extra walking and stuff like that, you know, my arthritis has improved, etc. Like, you know, and people see it's got to benefit them in some way, you know. It's got in self-management. It's getting those small wins under your belt as well from the get-go, really. You know, because when you've got those, you know, it's like going back to learning to drive. You know, you move off. You know, well, we're going to move off, and you know, you move off, and you drive. Like, oh my God, I'm driving a bloody car. Oh look, I'm still alive. You know, and people then the confidence, say yeah, oh, we're going to turn left now. Oh my God, I've got to turn left. So and then you start saying, oh my God, I've turned left and I'm still alive. You know, and then see the confidence goes up, and then there's people's confidence increases. You know, they think, yeah, you know, and whenever I'm doing workshops, like, you know, or talking to people, I want them to go away My main thing is the main message for me is they go away thinking, oh, you know, I think I can do this. You know, not like it's a massive mountain they've got to climb, but it's just that, you know, it's a process, but a simple one. It's got to be made fun. I learned that working with the Germans, believe it or not. Go to work and have fun. And then, as you know, if you know any German people, they're not renowned for being funny people, like, you know. It's yeah, so you know, just keep it simple, Brett. Seb, like, you know, have fun with your patients. Don't be boring. Not that you are. Hey, Susan, what's going on?
Seb had a great question in the thanks for that, Pete. That was awesome. I love that. And I love who was it? Helen, was it you that right? Don't pimp your ride, learn to drive. That's so good. So good. Oh, I love that. It's awesome. Seb had a question in the chat. Mary mentioned people with persistent pain facilitating peer groups is a role for individuals who don't have pain. So that's what I've done a lot of my career. And much to my institution's chagrin, I would keep the people who'd been there a long time and really understood this, and they would be sort of my co-facilitator. And I find that works really, really well, because we can often explain the science of why something is happening. But the people with pain have such valuable experiences that I think, you know, if I were to pick one, I'd probably say a person with pain to just facilitate it, because I think we do, if you don't have pain, you run the risk of, yeah, I'm the expert, let me tell you how to live your life. But having both, I've found just incredibly valuable. And one of my best learning moments that they've all been in those groups, co-facilitated. Often I'm usually 2 or 3 people that are sort of the support group experts. Actually, we call it sharing solutions. We don't call it a support group, because support can get very whiny sometimes. And we want to make sure that everyone's nervous system can manage. But it's a great question, and there are some pitfalls with just having one, but yeah. Thanks for that question.
Virginia?
Yeah, just to build on that, within our peer support groups, they are volunteers, peer supports who are trained. And in Canada, we have 4 organizations who the peers facilitators do the training together, and this compensates that. But I think if you end up bringing in healthcare providers leading these groups, you then become a power imbalance. People won't share as freely. People will take what you say and not argue it. And not that they should argue it, but they should be able to say, oh, I don't know if that'll work for me, or something like that, you know? So that's, you know, and this way our groups are not structured, like Mary had said in the chat, the self-management classes, there's a structure to it. There's certain things. So ours are all people who live with pain, with having healthcare professionals come in as guest speakers, is how we kind of do ours.
There's definitely that risk, Virginia. I think maybe what I didn't say is how I run them. I don't say much. I provide the bottled water, and when they have questions, I kind of make sure that it doesn't get out of hand. But yeah, and so yeah, that's a very, very, very valid point, for sure. I don't, maybe in the beginning there seemed to power imbalance, but I really don't say very much unless they're struggling with the science part of it. Yeah, for sure.
It's perfect. You come provide water at ours, we'd love that.
Yeah, that's all I had, water and napkins.
I just had a message from Alex Chisholm. You know, I told you about a group she's doing in Alberta. It's a new service, so they haven't really got a waiting list yet. So I dare say there will be a waiting list at some point, though. But fantastic, you know. I mean, it's I mean, Alberta, is that a massive province? Is it one of the biggest provinces in Canada?
It's a good one. It's a
It's
good
yeah,
one.
it's a good size. It's a good size province. We got 2 big cities in here, which is for Canada, having 2 big cities in one province is significant.
Okay. All right.
But it's probably
What
the
I know
third
about-
most populous. Would you say the third most populous? Ontario, BC, Alberta?
I'd say probably like Ontario, Quebec, maybe.
Oh, Quebec.
Quebec,
Yes.
yeah.
That's good. Yeah, in this program they have this. This is fairly new. Actually, one of our facilitators is actually going to co-facilitate with them. It's going to be like a certain program and have a healthcare provider and a peer, and they'll do their set, and then hopefully go into the what's next, the peers, eventually roll out a peer support too. But it's very, very new, and I'm excited to see it all roll out.
So listen, we're coming up to time soon. We've got 5 minutes left. So let's round it up for this this session. I'll stop recording after we've finished, and perhaps we can talk about another the next day. But meanwhile, is it possible that you can? What's the take-home messages you're going to take away from today's conversation? What's your take-home message, Jerry?
I'm going to take, you use it every time, Pete, whether you realize it or not, but it gets more valuable every time. Your example of driving school. And my take home here from, and this is a combination of everybody, it's impossible not to attribute any of my thoughts to each of you individually, but everybody has said something. And I'm going to jump with Pete and Dave though, because they're sticking out right now. I believe I was listening for Dave. I love to go to the patients. I love to go to the people who have been in, by the way, any business on the face of the earth. If I want to be successful, I talk to past customers and clients. Now, we understand healthcare. Our past customers and clients are patients, which may be a little uncomfortable, but they are the most valuable. They are the most valuable holders of information and feedback to be successful going forward. And the successful people as much as the people who didn't have success with the business. So taking what Dave said and taking Pete's analogy is I believe we need to be Sherpas in a journey. The Sherpa mentality, it has to be, and that's the car driver, right? That's your car mentality. Example, Pete, you're in the seat next to the person who's doing the activity and you are the guide. And then back to what Dave, so we have to take the Sherpa mentality. And then back to what Dave said, there's a lot in there. And yet my takeaway in the context of all this is we're not going, I'm going to say this out loud. We're not going to change this system. What we can change is what Dave mentioned. We grow up in believing something about a system. So it's again, going back to I'm going to say the bottom, and by bottom, not derogatory, it's the grassroots, it's bottom up. I'm going to go to the bottom, which is the people who haven't been in the system, right? So the people as masses. Helen, you made a great point. We're talking about people who have no power in their life, and we're telling them self-manage, right? So if we go straight to the people, I believe we solve a lot of problems at one shot instead of waiting for someone. Okay, let's sit back and wait for the pain patient to call. Let's wait back. So again, there's so much here, but again, this idea that we can't change the system. So let's think about educating the people. Let's use this word education. And then let's take the Sherpa mentality. Let's come alongside everybody, anybody, right? And again, Helen, you had a great example. Just come alongside people and let them know it's okay. Or I want to understand you better so I can move you forward in this process, but not the fucking system. And I said the F word because I have to say the fucking system. And I'll just speak for the American system at this point. So thank you. Thank you all. This was awesome.
Thanks, Jerry. Who's next?
I just want to pick up on something that I'm sorry, I didn't get his first name, McCoy, or who was here earlier. But he kept reminding us that there's been progress made and that there's hope. And I think I want to take that away tonight to say that there is hope. Progress has been made. Pete, you and so many others have paved the way. And I think someone else said it tonight, the groundswell is rising, and I'm encouraged. I'm encouraged by that.
Thanks, Helen. Who's next?
I can jump. Okay,
Go ahead.
Sorry. No,
Okay.
I'm going to just I'm going to build on to kind of what Jerry said. Is a lot of takeaway is come alongside the people. Be honest if you don't know self-managed, but let them know that it is there and there's other people doing it. Connect them with other people. Come to the bottom, bring in your community partners, and just listen, because by the time you get to someone who's been living with pain, they've been dismissed a lot, and there's that honesty is gone. So I think there's a really good starting point.
Thanks, Virginia. Who's
Yeah.
next?
I think I sort of ditto to what Helen said, but I think just the reminder to keep talking about it, because I've been talking about it since 2010, and I kind of have stopped because I've been seeing these successes. I've been seeing these things happen. And so I think the realization that we are still quite far away. And so to get back my horse back on that trail. Thanks very much for this, Pete.
Thanks, Susan. Mary?
Yeah, I think that progress does seem to be painstakingly slow, and it gets frustrating for all of us. I think that we can't expect GPs to do this, because I don't know about everyone else's country, but ours is just, they are so busy. They just don't have the time. So, but what they do need to know is that it works. They need to know about it, and they need to know where to send people, because then they're going to have patients that they're going to be able to work with more easily too. So I think that would be my sort of takeaway thought from here.
Okay. Dave?
Not to, yeah. It's actually been really good to hear healthcare professionals talking in a way that's putting the patient at the centre, as opposed to putting the medical model at the centre. So, yeah, I know we're all like-minded. You're all like-minded, hence why you're selected by Pete to attend the call. But apart from the international conferences that Pete's organised, I haven't heard as many people in the same room that are medical professionals talking in a way that's putting the patients at the centre. So I'm really looking forward to being invited to the next one, assuming I haven't annoyed people too much, so that I can, continue to be inspired by what you're all doing.
But the funny thing about these conversations is that people are asking to join it. I'm not going out there and saying, "Oh, we being selective." It's just people. Pete Durham said, "Oh, can I do it?" I think Jerry, you said, "I want to be part of that." Dave Flusk up there, can I be? And I suggested, Helen, do you want to come and join us and stuff like that? And I think the thing is, it's we're like-minded people. That and that's our common denominator, really. There's that we've got their interest is self-management. How do we roll it out? How do we nurture it, take it forward, etc. So, Seb, what's your take-home message from your first conversation?
Yeah, so great to be a part of this. Many takeaways, and I appreciate both the clinicians here and the people with persistent pain sharing their opinion. It's definitely helpful for me, and I'm sure it'll be helpful for a lot of others as well. Mary did kind of steal what I was going to say. But Jerry made he said something, and we all kind of touched on it, but he just said it very clearly. It was just about having to do things in parallel to get this going. And I think that's huge. I think if we do that and kind of approach it from both sides, it'll put less pressure on the healthcare professional, primary care physician, whichever they be, and the patient. Allow patients to learn how to advocate for themselves more. And that, I think that's what this conversation has been about, reducing barriers. We do that, and we're reducing barriers from both sides. So I'd say that'd be the biggest thing for me.
Well, thanks everyone. Thanks for everyone for taking part in this fifth conversation. Hope you found it interesting. I found it that when I do get involved with this, although I don't think I'm running it, I think it runs itself. But I always come away with it puts a lot of energy into my self-management sales, because we get a bit drained from all the can't do people. And it's being with some people for 90 minutes who are can-do people. So to me, it puts a lot of wind in my self-management sales. So we'll see you again on another conversation. Stick around, guys, so we can organise the next day and what we're going to be talking about. Take care, everyone. Bye.